Hello all, this is Dr. Kumar. Welcome to another masterclass series from Dentospedia. Today we're dealing with the fifth session of oral radiology, and today's topic is about panoramic radiography. Okay, and in this picture, can you tell the difference between the portrait view and the panoramic view? Okay, this is a portrait view. The area of interest is less. Okay, and you will get a small image with less number of pixels. And this is a panoramic view. You can get larger area of interest. Okay, the field of view is larger when compared to portrait view. Okay, and that's the basic difference between portrait view and panoramic view in dentistry. Okay, in our maxillofacial radiology, the portrait view is compared to IOPA or bite wing, because in IOPA or bite wing the area of interest is less, right? In IOPA you can get maximum of 3 or 4 teeth. Okay, if the teeth is larger you can get 2 or 3 teeth, and also in bite wing you can get maximum of 5 to 6 teeth in a single film. But in a panoramic radiography you can get, you will get all the maxillofacial structures along with teeth, bones, right? We can get all the information related to the inferior alveolar canal, right? And also we will get information regarding the maxillary sinus. So we will get all the information in a single image. So that's why panoramic view is compared with orthopantomogram in our oral radiology. Okay, so that's the difference, main difference between the portrait view and panoramic view, and why we are comparing these views with our radiographs. Okay, coming to introduction to the panoramic radiography, it is a specialized extraoral radiographic technique. Okay, it is also one of the radiographic techniques used extraorally. Okay, and what we are getting, so we are getting the both jaws, maxilla and mandible, okay, in a single film. That's the specialty of the film. Okay, and it is also called rotational panoramic radiography or pantomography. In this technique, the film and the tube head, that is X-ray source, rotate around the patient, and the patient remains stationary throughout the process. Okay, and the X-rays, the X-rays are directed towards the patient, right? So we'll get series of images, and then these images are combined to form a big image. Some small images are taken by the mission, right? And then these small images are combined together to form a large image. So that's why we are getting a large field of view from this OPG. Okay, and I want you to understand few important points before you understand the basic principle how CBCT works. Okay, and this is the level one. So consider there are two discs. So disc one is fixed and it only rotates around its own axis. This is the axis of the disc one. Okay, it rotates counterclockwise, and there is disc 2. It is fixed in position and it only rotates around its own axis. Okay, and it rotates clockwise, just opposite to disc 1. Here there is X-ray source which is fixed in position, and then we are exposing these discs with X-rays. Here there are letters ABCD. Okay, so during the exposure, these one disc 1 and disc 2 will be rotated, and the images of ABCD will be present on disc 2. Okay, so disc 2 has a film, so disc 1 has an object, that is we can say subject. Okay, ABCD are the subjects in this example, and disc 2 has the film. So when we are exposing the X-rays, the letters ABCD will be present on the disc 1, will be projected onto the film, and then we will get the film. And I want you to understand how this works. Okay, so observe carefully. So the rotation has started. The both disc 1 and disc 2 has started the rotation. Okay, and during the initial rotation, we will get the A is exposed to X-rays, and the film catches the image, and A image will be present on the film, and then B, then C, and D. Okay, so you understood the mechanism, right? And coming to the level 2, this is level 1 we discussed, and coming to the level 2, here The setup is the same, but there are slight changes. Here, the disc one is fixed, and there is no rotation. Okay, and in disc two, it rotates and also it revolutes around disc one. So rotation is nothing but it is taking rotation around its own axis. Okay, and revolution is nothing but it is taking taking another turn. It is rotating around disk one. Okay, just like Earth rotating and revoluting around the sun. Disk two is rotating around its own axis and also takes revolution around the disk one. And also X-ray source simultaneously rotates around disk one. So for the whole setup, the center of rotation is this one. Okay, this point is the center of rotation for the whole setup, not only disk one. So disk one is fixed, then there is no rotation here. Okay, and for both disk 2 and the X-ray source, this is the center of point of rotation. Okay, and around this, the disk 2 will be rotated and X-ray source will be rotated in opposite directions. This is clockwise direction, and X-ray source is moving in counter. So both are moving in clockwise direction. Okay, and I want you to observe carefully how this works. So the initial turn has been done. The letters A is projected onto the film, and then B, then C, then D. Here you can observe the disc 1 is not rotating around itself. Okay, it is fixed in position. Only disc 2 is rotating around itself and also taking revolution, and X-ray source is moving around disc 1. Okay, so the same formula applies here in panoramic radiography. Here you can see in our second example, right, level 2, disc 1 is fixed and no rotation, right? And this can be compared with our head. So during exposure of OPG, that is orthopantomogram, our head is fixed in position without any movement. Here the film and the X-ray source are moved around the patient's head. Okay, it is rotated around the patient's head, and then they capture the small images, and then they gather all the small images into one film that is called OPG, that is orthopantomogram. Here disc 2 can be compared with the film. Okay, disc 2 has a film, right? So disc 2, it rotates around the center, that is this is the center for the whole setup. Okay, here you can see the disc 1 is replaced with our head. Okay, this is a mandible, and the film and the X-ray source are rotating around the patient's head. So there is a small filter called lead filter. Okay, this is a collimator which is usually present in every radiographic device. Okay, and disc 1 is replaced with the head. So this is the principle behind the working of the orthopantomographic machine. Okay, here you can see the tube head rotates around the patient, and also the disc with the film, it rotates around its own axis, and also it rotates around the patient's head. And we have discussed, right, there is a single point of rotation for the whole setup. But when it comes to maxillofacial radiology, we have multiple centers of rotation. Okay, so these are the centers of rotation. When we join these centers of rotation, we will get this kind of arc. Okay, that is called arc path. It is nothing but it is we just we just drawn a line on the centers of rotation. For example, if the molar is a point of interest, the center of rotation will be here. And if the point of interest is the premolars, the center of rotation will be here. And if the point of interest is mandibular incisors, the center of rotation will be here. So when we combine all these centers of rotation, we will get this kind of arc. Okay. And what is image layer? So image layer is very characteristic feature of this kind of radiography. Okay, it is not present in another techniques. Okay, image layer, which is also called focal trough, which is also called focal trough. It is a three-dimensional curved zone where structures within it appear clearly on panoramic radiography. So it is a three-dimensional zone which is kind of a horseshoe shaped, okay? And those structures only which are present in this zone are able to get its position, are able to get its place in the final radiographic image. And those structures which are not present in the focal trough, they don't get they don't get its position in the final image. So if at all, these out of zone structures, if present in the film, they might be either distorted in shape or size, they might be magnified, so they don't appear clearly. So that's why we have to place the patient during the exposure such that the patient's head is well within the focal trough. Okay, every mission has its focal trough region. Okay, the radiology technician has to calibrate the device so that the focal trough is well within the limits. Okay, and also during the positioning of the patient, the technician has to take care that the patient's oral structures are present well within the focal trough. Okay, so the only structures which are present in this layer are able to get position in the final images, and if they are not present in the focal trough, they might be blurred, magnified, or reduced or distorted. And the shape of the image layer varies depending on the brand and design of the panoramic emission. So the shape of the image layer might change. There is no drastic change, but there are some few minor changes in between different companies of panoramic missions. Okay, and there are certain factors that are affecting the position of the image layer. Okay, that are affecting size and position of the image layer. There are mainly four factors: arc path. So arc path we have discussed, right? This is the arc path. They are nothing but the line that is connecting the centers of rotation, velocity of the receptor and the X-ray tube head. Okay, alignment of the X-ray beam, collimator width. So these are the important four factors that are affecting the size and position of the image layer. Okay, so this image layer that is horseshoe shaped, and those teeth, we have to position the patient in related to the image layer. Okay, so these are, you can see the block diagram of exposure. So with prolonged mission use, the location of the image layer can shift and requiring calibration if images are not optimal. Okay, so on regular use of the panoramic vision, the image layer might get disturbed in its position. So the radiology technician has a special duty, to check these position of these image layers, and it should be calibrated once in a while to get good images. Okay, and how do we know, what kind of defect appears when the structures are not present in the within the image layer, right? So there is an experiment, there is an illustration. Here you can see there is a small metal ring attached to the mandibular anterior region in between the two mandibular central incisors. So the position and shape of the ring, you observe the position and shape of the ring based on the mandibular position. Okay, so whenever there is position change in the mandible, in and out of the image layer, the size of the image ring will be, it changes from normal size and shape. Okay, we will discuss this. When mandible is centered properly, so well within the image layer of focal trough, the magnification is even and proportions are correct. So if you place a patient well within the focal trough, we will get the image that is evenly magnified and also proportions are correct. If the mandible is positioned 5 mm anterior to the focal trough, the image becomes horizontally compressed, appearing thinner. Here you can see this is the initial position, right? So when the mandible is positioned anteriorly, you can see the radiographic image. It is kind of a thinner horizontally. Okay. And when the mandible is positioned posterior, 5 mm posterior to the focal trough, so this is the original position, right? This is where the focal trough is present. When the mandible is positioned 5 mm posterior to the focal trough, we will get, the image of the ring will be vertically compressed. Okay, if it is positioned anteriorly, it is horizontally compressed, and if it is positioned posteriorly to the focal trough, it is vertically compressed. So this illustration gives an important statement why the why we have to position the patient during the exposure, right, well within the focal trough. Okay, so this experiment or kind of illustration gives importance of placement of structures within the focal trough. Okay, panoramic radiograph has a definite and serious disadvantage. So as every technique has its own advantages and disadvantages, this panoramic radiograph technique has its own disadvantages. You know, the first and foremost, complication, or we can say disadvantage, is the presence of ghost images. Okay, suppose if the patient has worn any ornaments during the exposure, and radiology technician has not been aware of this situation, when we expose such patients, there is in this example you can see the earring, right? It is not removed by the patient before the exposure, and when we expose this patient, we will get this kind of radiograph, OPG, and this is a real image, and this is a ghost image. So this is a replication of the same real image on the opposite side, okay, and slightly upper and bit magnified, okay, and this is called ghost image, and this is the real image. So it hampers the diagnosis, right? Suppose if we are expecting some kind of cyst or tumor in the maxillary third molar region, if there are any ghost images appear in the radiograph at the same location where we are looking for cyst or tumor, it hampers the diagnosis, right? So that's why we have to instruct the patient to remove all the ornaments on the patient's head and neck region, okay, to avoid ghost images. Okay, so it is mainly seen on the opposite side of the film and slightly higher level, okay, and it kind of magnified in uh, size, okay. And there is a simplest explanation for the OPG. How OPG image is getting, how we are getting all the structures in a single image, okay. So it can be compared with the similarly like opening of a book. It's just like, compare the skull with the book, okay. We are just opening the skull from the back side and putting on the side, okay. We are just opening like a book. So this is a very simplest explanation how OPG image is, we're getting how these kind of images in oral radiology. So this is the final radiographic image where you can see all teeth, maxilla and mandibular teeth in single image. We can get the mandibular structures, ramus, condyle, the inferior alveolar nerve, the symphysis region, the sinuses. These are the cervical vertebra, right? So this is all about OPG. And coming to the advantages, there are mainly few advantages of this OPG. It is mainly used for visualizing maxilla and mandible in one film, for patient education, for evaluating impacted teeth, okay, and also in syndromic situations where we can use it for evaluation of supernumerary teeth, okay. For example, few syndromes, Gardner syndrome, right? In those situations where multiple teeth are present, supernumerary teeth, so we can use OPG for evaluation, and also we can evaluate the eruption sequence and pattern and growth and development of the child, okay, and to detect any pathology involving jaws like cyst and tumors, right, and to examine the extent of large lesion, okay, to evaluate any jaw fractures, maxillar mandibular fractures, and for those patients who are having limited mouth opening. So in intraoral projections where the patient has to open mouth at certain level, okay, and but here in OPG we don't need much mouth opening. So it is very beneficial for those patients who are not having much mouth opening. And to identify diseases of temporomandibular joint. For example, if there are any suspected cases of TMJ arthritis, TMJ osteoarthritis or any TMJ related conditions like any TMJ ankylosis cases. So we can evaluate all these cases, and also we can evaluate elongated stellar process. So there's a syndrome called Eagle syndrome where there will be elongated stellar process, okay, and because of that certain manifestations occur. So in order to evaluate this condition, we can use OPG, okay. And what are the disadvantages? There is a lacking of fine detail. So it's just like it's like a big picture with less number of pixels. Okay, if for example in your real life you can see the images, right? With less pixels you can't get the good clarity in the images. There is no good resolution. Okay, so it is similar to like that. So even though we can see larger area of interest, we can't get very fine detail like any periapital cyst, very small cysts, and those info can be uh, can be obtained in IOPS. So IOPS have more resolution when compared to OPG. So that's why based on our diagnosis or suspected diagnosis, or we can say differential diagnosis, we have to use different kinds of radiographic techniques. Diagnostic limitations. So you can't observe very small cavities, right? And also you can't observe very small lesions in the OPG. And in these conditions, IOPA and bite wing are advantageous. Anatomical overlap, okay, and during the OPG, all the maxillofacial structures are present, right? So if there are any, it can hamper the diagnosis due to overlapping of structures. Image inaccuracy. Sometimes, distortion can occur, ghost images can occur. So these are all can hamper the diagnosis. Focal limitations. So we have to position the patient well within the focal trough, right? And if there is any slight deviation in the position of the patient, and also if the position moves or it position disturbs his or her original position during the exposure, we might get distortions or magnifications or radiographic errors in final images. And also lead for supplementation. So we can't rely on OPG, on single OPG for diagnosis. So we have to use, in sometimes we have to use bite wing, we have to use IOPA based on our requirement. Okay, we can't rely on single radiographic images. Okay, and this is all about orthopantomogram. Okay, hope you understood this concept well, and we'll meet again in the next masterclass series. Okay, thank you.